Early studies that I always thought was a beautiful demonstration was pacing the ventricle, and what you would see is VA Winky Bach. So you'd see a VA get longer and longer and longer, and then what would happen? Then it would turn around with an echo beat. VA, 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 echo. And that gave a bit of a clue, right? So that you could see because you saw the actual echo and you knew the last beat turned around and came back down. So what does that imply? That implies it set up a reentry circuit in the AV node. Now, can we say for sure that it's not? So what a lot of people started to think was what's really going on in the AV node antegrade is there is delay, there's more delay, and then there's an attempt at reentry, but because of concealment with the next beat coming in it, you don't see it. And so you just get blocked. And so one of the theories for Winky Bach is a progressive increase with a final turnaround through the other pathway, the slow pathway, the fast pathway, but with retrograde concealment, and they collide so you don't see it. Because retrograde, you'll get this phenomena that you can see. Now, whether that's true or not, no one knows for sure, but it's one of the proposed mechanisms. So things have a reason, right? You don't just suddenly get, progressive prolongation. There's going to be a reason for it, right? So I like to think physiologically. And anyway, that's the theory I like. It doesn't mean it's the only one, but anyway, that's probably it's at least a tenable theory for antegrade Winky Bach. So if you can have that, why can't you have a concealed reentry loop in the His? I mean, it's theoretically possible, right? So I'm going to stick with that.
So this is an alternative thing, but if you have a PAC or a PVC that blocks, particularly in a patient as a bundle, what you do is you create a long HH interval. And that long HH interval, results in increased refractory period, and that's why you get blocked. You get blocked where? Below the His bundle. So these are the characteristics. Eric's already talked about this. The site of block is felt to be, it's phase 4 block in a more distal area. That's the other theory. Phase 4 block is terminated by a junctional escape complex, PVC, that likely originates in a site distal to the site of phase 4 block. Again, all theory. And restore the escape complex retrogradely excites the distal His-Purkinje, responsible for phase 4 block, restoring a more normal transmembrane potential, permitting successful subsequent conduction to the ventricle, and a retrograde conduction in the His-Purkinje system responsible for phase 4 block. So this is just a slide that I made to sort of illustrate the other theory for paroxysmal AV block, which is what people call it. They don't call it bradycardia, but paroxysmal AV block, and that is you get block here, and that results in a decreased transmembrane action potential, and that's why you keep on getting until you get concealed conduction and distal and restore transmembrane action potential, then more proximally subsequently. So I didn't do this study, I didn't do this experiment. It's just a schematic diagram that has been used to try to explain how a PVC, which is by far the most common way conduction is restored, as Eric said. It's typically a PVC. He showed you a PAC of the cases that exist in the literature, not the cases that exist, people have. I'd say 80 to 90% of the cases I've seen, a PVC initiates and a PVC terminates. PAC cases, I've seen 1, maybe 2 in my whole lifetime. Very rare, but this
Mine was a junctional, though, not really a PAC.
Right, that's true. And probably all the PAC cases are probably junctional.
Yeah, they are probably junctional. So, Ken, the only thing is, okay, that's the other thing. My challenge to you, without getting too much in the weeds, is when they're going 40 beats a minute at night, why aren't they blocking? I mean, if that's the theory, if you have diseased His-Purkinje and phase 4 depolarization is abnormal, then it's abnormal. That's what happens with a Brady left bundle, a Brady right bundle. That's the theory, right? So why is this the only case of all the concept of His-Purkinje phase 4 that doesn't fit that rule? Is the rule wrong? Or is the
maybe,
thing,
as you said, it's a sudden change in rate
Right.
that causes the problem initially, whereas in sleep, you're sort of vaguely drifting off. And so
Brady's Brady. I mean, you know that. How many cases of you have Brady dependent where it's there, right? It's there asleep, it's there. We're never going to figure this out. I guess all I wanted to do was give you an alternate view of the universe. This is the common thing. George is probably right. If it's on a test, go with it. But I'm just telling you, I don't buy it. I just don't buy it. And the study it comes from, the physiology has been discredited. Just remember that. It's like January 6th stuff.
Okay. Okay.
All right, we're going to let you go on your other stuff. All right, we'll let you. So we have a break. We have lunch at noon, Ishita?
Yes.
12:15. So why don't you take us to lunch? You want to do that?
you want to do your next case because it sort of fits into my
Oh, okay.
discussion.
Let me do my next, and then you go. Okay, is
great.
that okay? Or
Yeah.
you? One of
All
you
good.
two take
Good.
over.
You do your next
All right.
case.
The next case fits kind of into what we just talked about.
Yeah,
Right? Yeah.
and,
that's why
I'll
I put
go
him there.
after Eric,
Yeah,
and we'll
that's
finish.
right. And then you start after lunch.
Perfect.
You'll
I'll go
take
back
after-
to pacing.
This fits into my
Yeah.
my little discussion on.
All right. So
why
let's go back to
fluorescence
my
ain't-
next one. Okay. Very good.
you're not showing that one. Okay.
Oh, this is the, why you don't like this one?
Well, you had one before that where there's the famous, well, the one after that, I think, Eric.
Oh, you
It fits better a little bit.
think? Hold on a second.
That one.
Oh, that one. Well, I'll tell you, that's in our book, by the way.
Do it when you like, but it fits in
Let's
with
do this
my-
one first, because this fits
Do
very
both.
nicely. We'll do both. We'll do them a little faster.
Do both.
Okay, this one we won't get into an argument over. By the way, I hope you're okay with this bantering. You know, it's kind of like how we like to teach. But if you're just bored out of your minds, let us know, and we'll try to go back on the path.
They're just humoring us, Eric. No problem.
Well, I just think that, you know, one of the advantages of a course like this is that we can bring into something like this a lot of the history of the field and where things come from and some of the things that have been discredited and why they've been discredited and why we think a certain way now. So we think there's some value to that, but it doesn't mean you do. So if you'd rather just say, hey, Klein and Prostowski, just stick to the damn book already. We'll leave Ken out of this because Ken's just a nice guy. But George and I like to teach this way. We've done it for years because we think some of the side roads actually bring up the best discussion. So anyway, we'll do this from your seat. How about somebody take this? I'll give someone a mic. Who would like a mic to discuss this one? A table or whoever, because we'll move along a little bit. Any table want to discuss this one? No? You can do it. I like the attitude. We can do it. There you go. Let me get back up there so I can run the pointer. Does fit the last case, kind of, George, don't you think? And then we'll do the last one. Yeah, go ahead. Go ahead.
So
I'll use the pointer here.
we see P waves with a sinus morphology that march throughout the tracing. We see a PR that seems to be constant throughout the tracing, and it measures to be constant on at least here. And there is a P wave with a non-conductive that doesn't have a QRS following it.
Okay.
The QRSs that we see look to be typical left bundle. So there's an AV block here.
And if you stop there before you go on, if all you had was this, what would you call that? Which is fair if you don't have the rest of the tracing. Patient had syncope, was sent to me for study with syncope. So to forget the rest, just if you only had that to look at, what would you have called it?
Mobitz 2 block.
Yeah, I think that's fair. So it's Mobitz 2 by ECG criteria, right? But now you can go ahead.
Then the P wave, the conduction resumes with P and QRSs. I think there's one P wave that's actually the cycle length is a little bit variable now here. I think
I don't remember that.
So I think the PR of the return of beat 99. I'm guessing those are the beats numbers at the top.
Yeah,
Seems
it's
to be
an old
exactly the
Holter.
same.
Yeah, it's
Seems
an
to
old
be exactly
Holter.
the same as the PR.
You think that's somewhat short? Maybe a tad, but
I think it's about the same.
yeah, I did too. So go ahead.
And then there's a change in the P wave morphology,
Really?
I think so. I think the beat 100.
Really, when he says really, he means you're wrong. So
Yeah. I'm just
Clue.
doubling down on me being wrong.
I don't know. I thought it was pretty same. I mean, put your calipers on here. I mean, I can't measure it from here with this. Is the PP intervals pretty much on time?
Yes.
Okay. I mean, if you really, be careful calling the P wave out. What is actually the obvious abnormality? Because you're on the right track.
Yeah, the drop, not the dropped, but the P wave.
Right.
conducted
Yes.
QRS.
But why are you saying this beat's bothering you? Correct.
Yeah, because the PR.
So why is it bothering
The PR
you?
is different.
Right. So do you think it's a pre-excitation? Suddenly got a pre-excitation? So the PR is different. So let me ask you this. This is kind of George's, would be what he'd say. Do you think that P conducted to that QRS? I mean, the only way that to happen would have to be if the beat was pre-excited, right? I mean, the only way, it didn't go through the AV node, right? Because you know what the AV node conduction time is.
Yeah.
So is it pre-excited?
It doesn't look like a delta wave to me.
Well, what does it look like? Let's
it looks
think about
like
what.
it looks like a PVC.
What does it look like? If you look at the whole, look at the.
Ask if it's supernormal conduction.
Ken wants to know if it's supernormal conduction. That is just not a nice thing to ask him.
that's usually the wrong answer for ABIM.
That is really not a nice thing to ask him. Supernormal conduction, by the way, only occurs below the AV node. It never can occur in the AV node. So tell him no. Tell him no, it's
No.
not. There you go. Okay, so it's a short PR. Compare the 12-lead QRS on the beat, like George will say, the beat before and that beat.
They're the same.
They're the same.
Yeah.
So what would be the likelihood of a PVC giving you identical 12-lead QRSs? I mean, you can have 5, 6, 7, you can have 8 leads almost look the same, but 12?
Just spit it out for him. It's a junctional, okay?
Yeah, a junctional beat. Yeah.
Okay, go ahead, and then there's the rest of the tracing. So now, put it all together.
So this with Mobitz 2 block, and then a junctional escape beat.
Well, is it escaping? Escape beat would be over
a
here
junctional
somewhere.
beat.
Premature.
A premature junctional beat.
Go ahead. Put it all together now. So do I put a pacemaker in this patient? How many people want to put a pacemaker in? You guys had syncope. He's about 78 years old.
Oh, are you saying like the reason that other?
I didn't say anything. I'm
He's
asking
saying that
you.
the two phenomena are linked, all right?
So you think this is a his extrasystole that?
Do I think? I know what it is. I'm asking what you think.
So it's the fact that we see a junction.
But I'm going to ask you to do another measurement. So if you're going to opine, and I'm with you, you're doing a great job, that manifest, now you have a manifest junctional extrasystole. It's not an escape beat, right? It comes premature. Now what you want to do is, in your mind, remember that first slide I said, think of intracardiac intervals. So think to yourself, if that's a junctional, then if I was in the lab, I would see a hiss in front of it, right?
Yes.
That's a junctional beat. So think of that, then put a HV interval in your head in front of that and move it back to that P wave. So what I would ask you to do is say, okay, I'm going to call this a manifest junctional premature. Okay, I think it's a great call. I'm with you. So the hiss is probably somewhere, like remember George was using on his thing. This is where, if you don't have calipers and you got this, what do you call it? What is it called? The machine you use?
The pixel stick?
Yeah, I don't know that program.
Adobe?
Adobe or
Oh, the Photoshop.
Photoshop. Yeah, if you had that available and got your calipers and all that stuff up here, it'd be a lot easier. But you could use calipers too if you didn't have that. I can't eyeball it here for you, but you would guess that the hiss is somewhere 40 to 60 milliseconds in front of that. And then if you take that over to the P wave that didn't conduct, and the best way to measure that is take a fixed point, measure this to this, and then move it over here, this to this, and it would probably be right about here.
Yeah, where you're measuring where the concealed.
Yeah.
extra
So does it
would be.
fit?
Yes, I think so. Let me see.
So how about now? Does it fit? So do you do intracardiacs? So this is the tracing.
Yeah.
This was probably in the 80s I did this because I had to prove to the doc nicely that he actually sent me a patient that didn't need a pacemaker. So I did the study and said, oh, we found out it was something else, because you don't want to screw your referring docs. There's a prime rule. Never call a referring doc stupid. It's just a dumb move, right? Because you won't get another case.
Yeah.
So
It fits,
figure out a way to make them feel good. And I said, we had to take him to the lab. And, it turned out not to be this great case. Thanks for sending it. When you had the whole diagnosis on the EKG. So, but having slides is fun too. So anyway, we did this. So anyway, isn't that nice hiss?
How did you treat it, Eric?
Well, interestingly, I tried giving him Proc because he was having a lot of this. And there's a case report by the late Ken Rosen from Chicago, University of Illinois, kind of tongue-in-cheek. I think it was in chest. I can't remember exactly. Quinidine, what it was a patient who kept having all these extra systoles causing Mobitz 2. The guy was getting dizzy. And he gave quinidine, wiped out his extra systoles, and Mobitz 2 went away. It was like cutesy. I think that's what it was called. I know it was Ken Rosen who did it. So I figured I'll give him Proc. In the lab, I was very excited I was going to replicate this. Didn't do anything. So we gave him a monitor, and it turned out he had vasovagal or something. But if this was a real problem and it kept happening and making him dizzy, you'd have to do something. You might even have to put a pacemaker. I've never happened, though. I've never seen anyone actually have syncope from this. I've just never seen it. It probably occurs. So anyway, though, I just want everyone to see this, though. Here's the his extrasystole.
It's a premature.
They're always premature.
Yeah.
Oh. Yeah, I'm sorry. Just didn't add the extra name. Premature his extrasystole, right. Sorry. You're right. You're more correct. And it occurs here. It doesn't go here. And it doesn't go here. So if you didn't have the manifest and you had an elderly guy with a left bundle and a history of syncope, and I'd probably put a pacemaker in him, to be honest with you. But you got to look for these things. This was like one piece of a whole Holter I came across. His EK, I found it, but I didn't. It wasn't like all the time, and I got lucky. I just kept going through it, and I said, "Oh my God, I got the answer." I was very excited by it, But if you didn't have this, George, I probably would put a pacemaker.
Yeah, but 99% of people would have said what you said. So I mean, this is not a common thing.
Yeah.
But I guess my take-home
You'll never
message
see this
is,
again. You'll never see this again.
Yeah, I've seen one.
This is
One.
This is beautiful physiology, but no one is ever going through Holters like that and noticing the
I
junction.
did.
You did.
All right, there's the
but
practical and the
yeah,
theoretical, but
purely intellectual, academic. People would see the Holter, they'd say left bundle. Anyway, there's data in patients. How do you work up somebody with left bundle and syncope? Do you put an ILR in them? Do you give them a 30-day monitor? You find nothing, they get a pacemaker. That's the strategy your Canadian folks just published in Circ A&E in the last couple of months. But they get a pacemaker. So no one will ever do this. You'll never see a tracing like this again.
Ever again.
So you should learn from this because
It's in our book, by the
this is pure
way.
physiology. No, I'm serious.
You can read about it.
How many who has studies patient with left bundle with syncope?
I don't, but I
a
always
general
look.
teaching point.
Yeah.
But he look for it. But
General
I guess
teaching
he's not
point
saying
is-
don't look for it. He's
No,
just
I'm-
saying you probably
Yeah,
won't look for it.
People don't do this anymore. They're just so busy. They're just going to do what's expedient. They won't take the time to
Yeah, George have a comment. then
I
we
just
have
had a quick
question.
comment.
Yeah, go ahead.
Just from a general teaching point, the crux of this case, especially from an examsmanship point of view, was beware of coincidence, huh? Beware of coincidence. So why, and junctional extrasystole aren't that bloody common, right? So beware of the fact that he's showing you something with an AV block and then he's got a junctional extrasystole. Why, you got to think about some connection between the two. So junctional extrasystoles can be manifest, they can block to the A, they can block to the V, they can be completely concealed, all right? So all permutations and combinations. And there are stuff in the low, I've had a few where you can see all of the above. You can see block to the A, block to the V, and then nothing, because it's blocking on both, in both directions. So it's beware of coincidence.
So, like, just to solidify this for myself on the previous trace, on
Yeah,
actual
sure, I'll go
ECG
back.
itself, the clue here is that the PR, the changing in the PR.
No, the clue is that you've got a junctional extrasystole manifest,
But yes,
closely following. Also, commonly, another common thing you see, I mean, it's relatively uncommon, but you see variable PR for no reason.
but to recognize it as a junctional extrasystole, for me, it involves like seeing that it doesn't make sense with the PR interval that's conducted.
The P wave hasn't changed, and a
Yes,
junction,
that's
just
what
the
I mean.
PR is too
Yes,
short to
that's
be
what I mean.
believable.
You're correct.
So when
Yeah.
you see a AV block with changing PR intervals, on the differential of that is junctional
Well,
extrasystole. Is that fair to say?
You're taking it a little. I don't want to say changing PR intervals. I think because it's really not changing PR. It's just a pseudo, right? It's really yeah. So I think the better way to think about it is the summary is that, and this has been called, which I hate this term, George. You know what I'm going to say? Pseudo Mobitz 2, because it's not pseudo Mobitz 2. That left part of the tracing is Mobitz 2 as he described it in his earlier literature. No change in the PP interval, no change in the PR, sun non-conducted beat, period. That is Mobitz 2. It only becomes pseudo because there's another mechanism, but it doesn't change the ECG criteria. That's a stupid term, and I won't even bother you the guy who did it because he's very famous and he's a friend, but I think it was a dumb term, okay? What I would rather you do is kind of what George is saying. Not worry about changing PR intervals. Be on the lookout for a junctional beat wherever it occurs. It could have occurred it could have occurred with the PR almost normal. I mean, it could have occurred just you know what I'm saying? You don't know where. So it's just be on the recognition that if you have a manifest junctional beat, then you could have a concealed junctional beat, and that could be the cause of the Mobitz 2, if it's placed right. That's the way I would think of it. We have a guy in the back first.
like 3 questions.
Yeah, we have 3. That's okay. We'll take it. Yeah, go ahead. You got your answer. I'll get to you. We have a question here, then I promise I'll get to you.
Just a question. Why did the first one block, the first premature junctional beat block, but the second one did not?
That's more of a religious question. No, I'm teasing. You see this all the time. I mean, most of the time you just see junctionals. They won't even cause a concealment. There's probably, I mean, look, I didn't see it in the tracing. When he was in the lab, I kept getting these. If you got probably could be milliseconds. In other words, we keep talking about refractory periods. You need to know if you're in the lab, if you guys, ladies and gentlemen, get in the lab, do yourself a treat. Don't necessarily just go right to the left atrium and isolate the pulmonary veins. Learn something. Do something we used to call electrophysiology study, because that's how I learned. I did a lot of things I never even published that I'm spouting off because I just sat in the lab screwing around and trying different things. And sometimes I'll put in the same premature interval 20 times in a row to try to teach the fellows. And 10 times it blocks in the AV node and 10 times it doesn't. Because if you're off 3 milliseconds in the absolute refractory period, you'll conduct or not. So almost surely what's happened is there's some slight difference in the HH interval. But am I going to be able to pick it up on an ECG? Probably not. But there's got to be an absolute refractory period where it doesn't conduct, and then one where it gets through. And if you play with that in the lab, you'll see it.
But he makes, I think, a very important point implicit, why would a junctional extrasystole sitting way out there block to the V? That suggests that there is some disease.
Oh yeah, there's definitely disease.
Right, so so there is some disease.
Yeah,
so
and you can see
you can make an argument
yeah.
for a pacemaker purely because of that.
Yeah, there's definitely disease in the His-Purkinje system. And I have another case that George knows that I didn't bring both, that I also did intracardiacs. And it's really, and she has a normal His-Purkinje, and I have no idea to this day why she did it. It's a whole different case. I won't go over here. But hers went away in about a year. I actually gave her tracing to take in case she ever showed up in an ER so people wouldn't be putting a pacemaker in. It's a long story, which I won't bore you with, but it's a funny story. But at any rate, because she came for a pacemaker because no one believed her. They thought she said she fell. The ER people said she passed out, and they were going to admit her for an acute pacemaker. And she got so pissed off that she left the hospital, called our office. I happened to be there. And she said, I want to see that. Somebody said Prostowski is pretty good at this. What? She said, referred herself. She comes walking in with this tracing, and man, it was like dessert. I was like, I know exactly what's going on here, you know? And I said, don't worry, you don't need a pacemaker. And she just left because they didn't believe her. They thought, they said, no, you didn't fall, you passed out. She goes, I fell. And they argued, and she said, I'm out of here. But anyway, so I said, here's your strip. We know what it is. Keep it on you. So anyway, there's probably some slight change. I mean, there's an absolute refractoriness. And sometimes you hit it and sometimes you don't. When you're in a lab, play around with that. Just sit there and just run the same interval 10, 15 times. And you'll be amazed. Sometimes you block, sometimes you don't. And it's the same interval. But all you have to be off is 2 or 3 milliseconds. And it will conduct. So I wouldn't get too hung up on that.
There's a question also.
Go ahead.
The question that came through is,
these are internet. These are online questions.
would you pace a patient if he or she only gets few 2-to-1 runs on extended monitoring? In other words, wouldn't
No, I wouldn't pace her.
His-Purkinje disease manifest more, especially at high
No,
rates?
I wouldn't pace him. I wouldn't pace him. Does that answer the question? Yeah. Yes.
But legitimately, it's not one of those things that's guideline based because there's not enough data. His view is that someone might say, well, you know, His-Purkinje is pretty, you know, I don't want to take the fall for this patient falling and breaking their neck. So maybe I should put in a pacemaker. I mean, this is one of those judgment things, I think.
Yeah, I'm just talking to myself. I wouldn't pace him. But yeah, we have one more question. Well, sorry, I did promise. I promise I'll get to you. Yeah.
So did this patient have like multiple of these manifest junctional?
No, I went through this whole. I mean, I just sat there one day going through this whole damn thing. And you see, this is beat 99. I mean, I started at the beginning, and I just went. I think 1 or 2, and I just got lucky. I mean, I had the whole printout, and I got lucky. I mean, if I had never seen a junctional, we would have put a pacemaker in them.
So these extras basically just like come and go? Like
Yes.
You can have 2 within this long period, and it just happens?
This was in the early 1980s. Lord knows, I don't remember. I'm lucky I remember what you asked me yesterday. So, you know, I don't remember how many. There were enough I could bring them to the lab and get some nice pictures, but there weren't like all over the place. No, I just don't remember. It was too many years ago. Yes?
My question was, can his extrasystole happen in a healthy His-Purkinje system, or it's a sign
Yes,
of disease?
that's what this person had, this other person. But I agree with both of my colleagues. You hardly ever see it. There was no reason this person had, it was like, why is she having them? I mean, it was weird. And it was a little bit of history. I shouldn't say that. She had like an IVCD, but it was like, you know, 110 milliseconds or something. She didn't have a classic left, and there was no reason for it. And I was really surprised with her. But usually it's a disease, His-Purkinje system.
But his extrasystole with block to the V, right, a long coupling interval, suggests that there's something wrong with the His-Purkinje system, all right? So the one he showed, in my view, would suggest some His-Purkinje problem, because that first His extrasystole should have conducted to the V. They have a relatively long H to H.
And he said the patient had a left bundle, so...
Yeah.
So I promised you yesterday I'm going to take just a minute to tell you a tale, because I like to keep this tale alive, because it was so meaningful to George and me. We took the Pick and Langendorf course. Richard Langendorf and Pick were friends in Europe. This was the time that Germany was marching through, and both were Jewish, and Langendorf was here. And Alfred Pick was trying to get here. Louis Katz was their chairman of cardiology, and they were working on this whole concept of concealed conduction. And they did some of the real seminal work, EKG work on concealed conduction. And I'll never forget this slide, George. I don't know if it affected you the way it affected me. He shows this slide of concealed conduction, not with the junctional manifest, just you couldn't have figured it out, right? But you saw the PR lengthen, and you had to know that, concealment. I had read their stuff. I mean, I was prepared, but I wasn't called on this one. I wish I were. I would have gotten it right. So I was called on another one, which apparently I didn't get but half of it right. But anyway, at the end, Pick then tells the story. And it was really very moving. I mean, I still remember it, George. I don't know about yourself. It's like it was yesterday, that he says, this ECG saved my life. So apparently, to get him over here, Dr. Katz had told Richard Langendorf, send him a tracing, and let's see how he interprets it. And he sent back what he thought, saying it was concealed and so forth. So obviously, Katz was incredibly impressed with this. They hadn't even published their work. Paid for him and worked out a way to get him out of Czechoslovakia. I believe it was in Czechoslovakia. And otherwise, he'd probably gone to a camp and died. So it was like one of those moments I said that to myself, I'm going to tell this story at least once a year, because this was so meaningful to me. This one ECG saved this man's life. And so that's why every course I've ever taught, I show at least one case of concealed conduction. It's just a personal journey in memory of Alfred Pick. So I'll leave it at that. George, I'm going to let you take my slide because you're on a roll with this. It's in our book anyway. I'm going to go to the next one, but
very difficult, all right? So what I'd like you to do is at your table, I want you to answer the questions he didn't ask, but number one would be VT, and number two would be SVT with aberrancy, all right? One is VT, and just kick it around your table, and then we'll vote, okay? We'll give you a minute, all right?
Oh. So you all think of this a little bit, then I'll pick a table. Thank you. This table's too smart for me.
I mean,
we got a Victor.
volunteer.
We got a Victor volunteer. That's right. What was your question? Did you answer?
What were the options?
After we get 20.
What are the options?